and welcome. Hello and welcome to the next session in relation to health and well-being. I'd like to start by acknowledging the traditional custodians on the land of the ACT people, the land of the Ngunnawal people, and pay my respects to both elders past, present and emerging, and acknowledge the contribution they make to the city and surrounding region. I'd also like to acknowledge First Nations people who've joined us in this virtual room today. Thank you. My name is Sylvia Lappick. I'm the ACT Agile representative, and I warmly welcome you to this very exciting session this afternoon. Hopefully you've all had some time to stretch your legs, have some nice lunch, and you can settle in and listen to some of our speakers this afternoon. Now, just some housekeeping for those of you who may not have been in this morning's sessions. I'll just walk us through just a couple of things. So if you have any questions, please add them to the Q&A on the right-hand side of your screen. And if you have any technical difficulties, please use the live support button at the top of your screen. Now, to view this on the large screen, you can click the arrows on the top right hand of the video where I am now, and the screen will be larger for you. And what we'll do is I will introduce each speaker, and at the end of their presentation, we'll ask the Q&A questions on the screen. But if our time is up, we will ask the presenters to go into the chat and respond to some of your questions as well. Now, if we do finish this session a little earlier than expected, we will wait for the allocated time for the next speaker. But from this morning's session, I suspect that won't happen because there's always some really good questions that do come through. All right, now that we have the housekeeping out of the way, I'm really pleased to introduce our next session. Our next session is Collaborative Approach to COVID-19 associated with significant reduction in self-harm in young people in custody. And our presenters today are Dr. Leigh Haysom and Dr. John Kasinathan. Now, Dr. Leigh Haysom is the Clinical Director for Adolescent Health and Director of Medical Services providing adolescent healthcare and advocacy for young people in New South Wales custody. And we also are joined by Dr. John Kasinathan, who's a Senior Forensic Child and Adolescent Psychiatrist, a Conjoint Senior Lecturer with the University of New South Wales, and a Visiting Fellow with the ANU. His specialist appointments are as Clinical Director for Adolescent Forensic Psychiatry in New South Wales and a Medical Director for the Private Adolescent and Youth Inpatient Program at Northside Clinic, St Leonard's. His research and clinical interests include ADHD and comorbidity in young offenders and the appraisal of imminent aggression and reoffending in mentally ill adolescents, interpersonal drivers for self-harm in prisoners, and psychopharmacology addressing violence in adolescents and adult forensic patients, and the management of sexual deviance in youth. We welcome warmly our two presenters. Thank you.
Great, thanks very much for that, Sylvia. And I'll kick off. So good afternoon, everyone. I'm Dr. Leigh Haysom. Before I start, I'd also like to acknowledge the traditional owners of the many lands upon which we meet today. For me, in Sydney, they are the Gadigal and the Bidjigal people of the Eora Nation. My colleague, Professor John Kasinathan, and I share the clinical directorship of the Adolescent Health Directorate in Justice Health and the Forensic Mental Health Network. That provides the healthcare to all of the young people in custody across New South Wales, Australia. Today, we'll describe our collaborative response with our partner agency Youth Justice in tackling the first wave of the COVID-19 pandemic across the 6 youth justice centres in New South Wales and the surprising impact this had on the incidence of self-harm and related behaviours. Next slide, thanks, John. So at the start of the first wave pandemic in New South Wales, Health and Justice quickly realised that a closely coordinated response was necessary in the custodial setting, and we formed the Youth Justice and Adolescent Health COVID Response Committee, which met weekly to develop joint public health approaches to managing and containing the virus. We had daily updates with the New South Wales Health Critical Intelligence COVID unit. The committee reported to a statewide network COVID meeting and to the statewide Youth Justice Command Post. We also had regular formal and informal meetings with the nurse unit managers and the centre managers within Youth Justice. The response committee was multidisciplinary and interagency, and it included all of the relevant stakeholders. Both mine and John's roles, population health were very important, the centre nursing managers and the centre, the clinical nurse consultants, the manager of mental health and drug and alcohol programs in adolescent health, and the Youth Justice Director of Operations, Performance and Planning, and also the Youth Justice COVID Coordinator position. Thanks, John.
Okay, thank you, Leigh. I'll take over. So I'm going to talk a little bit about the vulnerabilities of young people in custody. What people people that don't understand young people in custody and don't understand the health implications sometimes don't understand the ramifications of a COVID-19 outbreak in a custodial setting. And it can be severely detrimental for the health of young people, but also all our other people that come into centres. But focusing on young people themselves, what research clearly shows is that young people in custodial settings have high rates of mental disorder. So there are elevated rates of psychosis, major depressive disorders, attention deficit hyperactivity disorder, trauma-related disorders, substance use disorders, and elevated rates of intellectual disability. Now, all of these mental health and cognitive domains can, just by themselves or even in combination, impair young people's capacity to understand and appreciate the preventative measures to reduce infection risk. We also thought that the necessary restriction of face-to-face family visits because of COVID-19 was likely to increase young people's distress and adversely affect their mental health. There's also quite strong research that shows that mental disorders can worsen under stressful conditions such as isolation, with self-harm and suicidal behaviour increasing. So because of this, the youth justice facilities were deemed a high-risk area for COVID-19 and also for subsequent health-related problems due to the nature of the environment and the demographics of our young people there, who generally come from low socioeconomic status environments. They're often disengaged from education, and there's high levels of comorbidity as well as poor nutritional standards for them. So the young people's needs and their behaviour really made physical distancing a challenge. I mean, all of us that have worked through this COVID pandemic have been abiding by this, staying social distancing and physical distancing from our work peers if we have to go onto site wearing masks. Try telling a 14-year-old that they're not allowed to high five and horse around with their mates in custody. It's virtually impossible to stop them. We also know that the mental health effects of quarantine can be quite detrimental. So research has shown that it can increase post-traumatic symptoms, can cause confusion, anger, anxiety, and it's worse for those with a psychiatric history or those with a history of mental health problems. And we know that young people in custody have high rates of this. And sometimes post periods of quarantine, symptoms of mental distress and psychiatric problems can be elevated for months.
Thanks, John. So the COVID response required a significant alteration in usual business practice, and everyone had a role to play. There was an emphasis on a coordinated and consistent approach across each of the 6 youth justice centres. The regular meetings and the reliance we each had on the other resulted in a very strong partnership that really hadn't existed before and continues today. Next slide, thanks, John. The adolescent health nursing staff educated all of the young people on admission in hand hygiene and correct cough and sneezing practices. And this was really received well by the young people. There was consistent messaging from the health staff and youth justice, which also helped to reduce the anxiety of the young people in that they were seeing us working really closely and collaboratively together. The nursing staff also educated youth justice on the correct use of PPE, something that they'd never had to do before. And it's, you know, it's not an easy thing to get right, particularly if you have never done it before. So the donning and doffing of PPE was something that was educated to all of the youth justice staff, which also reduced their anxiety about the whole procedurally driven process. Next slide, thanks, John. Oh, thank you. The clinics remained as clean zones in the centres, and so care was being delivered primarily down on the units where the young people were accommodated, and that also made them feel, you know, special and cared for. All new admissions to the centres were in cohorted quarantine, so in groups of young people, where they remained for the full 14 days of that quarantine period. Any young people with COVID-like symptoms or an elevated temperature were, of course, put in a single isolation room. All young people were tested for COVID-19 by staff in full PPE, and if they refused the swab, which isn't a very pleasant swab to have, they were considered a risk for COVID and were isolated for 14 days. Any abnormal results or any concerns were escalated to the network population health team.
I'll just talk about some of the responses from the mental health side of our health service. So we have a multidisciplinary staffing component to our mental health service. So there's myself as a psychiatrist with a whole bunch of other psychiatrists, but then we also have occupational therapists and psychologists and other allied health professionals. So we were thinking quite broadly about this, and so we tried to get sensory diversion. We got sensory diversion packs to all new young people that were put into custody, which included a stress ball, activity sheets, and playing cards. Because remember, whilst they may have had access to those things previously, they had access to things that other young people had used. And of course, with COVID, they needed to have their own set. So that's what we got to them. All young people were provided with art supplies, and we ran an art competition for young people, which produced some amazing artwork, and some of which we actually now use in our written material to young people to explain different things with their permission, of course. We cover the entire state of New South Wales, and that means that some of our centres are in regional locations, but of course air travel stopped. So our psychiatrists that were flying out to these centres once a fortnight were unable to do so. So we had to rapidly switch to video link, which some of our older clinicians found a bit more challenging, but we got there. Our mental health and drug and alcohol nurses were in each centre. They continued their usual business, so mental health assessment, treatment, addictions assessment and the treatment as usual, and they augmented the visits to the isolation areas when requested by primary nurses, youth justice staff, or young people themselves.
So the response from Youth Justice was very robust. They joined our health daily teleconferences and coordinated actions with the Department of Communities and Justice. They established a Youth Justice-wide pandemic plan with local centre action plans, a command post to coordinate all of their actions in collaboration with health, education and other stakeholders. They implemented screening questions for any visitors entering a youth justice facility, and they stepped up their own communication network. Next slide, thanks, John. They also reinforced the messaging around hygiene. They suspended personal visits, but they replaced those family visits with video visits, Zoom visits using tablets, iPads, and this was a really great thing for the young people because it continued their contact with their families, and often it was an enhanced visit because more people could actually be in the visit because they were videoing in from home, and you know the family pets could also join in those visits, which was nice for the young people to reconnect with their loved ones. Youth Justice operationalised quarantining of new admissions and the medical separation of any symptomatic young people, And they also did additional things like introducing temperature scanning on entries using thermal imaging cameras, also with screening questions and hand hygiene for any visitors. This is a very busy slide, and I don't expect you to be able to read it, but it's the flow chart of the operationalising of the public health response that we had. And I'll just, the young person arrives in the Youth Justice Centre, they would undergo COVID screening and have a temperature check. They would then be triaged into negative screening, reassuring temperature, or any positive screening questions and or elevated temperature above 37.5. If they were all negative, they'd go into group quarantine. If there were any concerns, they'd go into a single isolation room. If they're in quarantine and then went on to develop any concerns, they would be put into an isolation room. They'd leave group quarantine and isolation room after 14 days, having had negative surveillance swabs and being symptom-free for at least a 72-hour period. They would then join the long-term population in the main clean area, where there was also social distancing and hand hygiene observed at all times. This was a normal routine part of the centre, and young people were attending the clinic, school and external appointments from that main clinic clean area once they passed through those quarantine and isolation areas. And then we had a triaged discharge processes from the main area, from group quarantine and from isolation, because, as you know, young people come and go from custody, and being in quarantine really doesn't have any effect on their discharge planning and release from custody. Thanks, John.
And just checking in with you, Leigh and John, we have about a minute or so to go.
Okay, so we might
need to fast track a little bit.
Yes, we might skip ahead to the results. Thanks, John. So we all independently started to notice a dramatic reduction in self-harming related behaviours. And in March, April and May of 2019, there are 154 documented incidents. But in the equivalent COVID period in March, April and May 2020, there are only 35 incidents, which was a 77% reduction. And the next slide, thanks, John. We wondered if that was just reflected by the fewer numbers that were possibly coming in, but the top light blue line shows you that the numbers didn't actually reduce coming into custody between those two comparative periods across 2019 and 2020, yet the self-harming was significantly reduced, and this bar chart just reinforces that between those two comparative periods of 2019 and 2020. And when we looked at it statistically, there was a significant reduction from 20 self-harm episodes per 100 custodial admissions in 2019 to 4 in the 2020 COVID period, which is a 4-fold reduction and a highly significant result.
That be? Thank you, Leigh. We hypothesised that it may be because young people felt more secure, safe, cared for, and cared about. There was a lot more attention daily from staff, not just from our health service, but even from youth justice, in the form of welfare checks, wellbeing checks, physical observations every day, increased communication, and the visible changes in practical things like temperature checks, we thought related or conveyed that we were really caring for them. And we think they took that on board. We also talked about the innovations that we had to put in, or which we thought were best practice. So sensory diversion, the tablets were being used for family or AV visits, and our treatment and care continued despite COVID-19. So we kept doing our usual business, which is important in the health and well-being of young people.
So we realised there were some limitations to this study, it being a short-lived cross-sectional view from the original COVID pandemic year, and unmeasured potential confounders such as policy and procedural changes across. So we felt it needed future research, including perhaps some qualitative structured interviews of the young people and staff themselves, sampling across the centres, and perhaps a prospective analysis of the self-harm data to monitor for a bounce-back effect. And this slide just gives you a peek at some of that prospective data, which we haven't formally analysed, but it does show you that at the start of the second wave COVID pandemic in New South Wales, which began in March 2021, you can appreciate that there's been yet another significant reduction in self-harm rates, which does go to sort of reinforce some of our theories around, this effect. Thank you very much. That's it.
Wonderful. Look, thank you so much for sharing those insights in relation to COVID. We always hear about lessons learned during the COVID pandemic, but what you've demonstrated today is some real significant results, some impressive results for some of our young people in custody. So thank you so much, Dr. Kasinathan and Dr. Haysom, for sharing the presentation today. We do have one quick shout out from Mike Wheaton in the chat from Youth Justice New South Wales. A really big thank you to Leigh, John, and your other Justice Health colleagues that have helped us navigate the COVID-19 pandemic safely. And I think some of the insights and learnings that you have been able to look at in New South Wales have certainly application across a number of jurisdictions. So thank you for that.
Thank
All
you.
right.
Thank you.
Thanks to
Yeah,
Mike
that
as well.
sounds great. So look, I don't have any other questions, but if anyone has any other questions, please pop them in the chat, and both of our presenters will be able to share some insights on the chat as well. So thank you so much for your presentation today, and we might move on to our next session. So thank you so much.
Thanks, Sylvia.
Thank you. Thank you.
All right. So I'll move us on to our next session, and here we're going to, the title of this session is Navigate Your Health, Working Collaboratively to Change Young People's Stories Through Better Health. And our presenter today is Dr. Pauline Zardo from the Department of Children, Youth Justice and Multicultural Affairs. And Dr. Pauline Zardo is the Director for Quality and Improvement, Youth Justice Statewide Services in the Department of Children, Youth Justice and Multicultural Affairs in Queensland. And she completed a PhD in 2013 on increasing research use in policy, program and practice decision making. Pauline is interested in using research, monitoring and evaluation to ensure and demonstrate improved outcomes. We welcome Dr. Zardo to today's presentation. Thank you.
Hi everyone, thank you for the introduction, Sylvia. I'd like to start by acknowledging Aboriginal and Torres Strait Islander people across Australia as traditional owners and recognise their continuing connections to country, culture and community. I'd like to pay respect to them and their elders past, present and emerging. I'd also like to acknowledge and pay respects to the people of the land, Tangata Whenua of New Zealand, Ngā mihi kia koutou. So today I'll be taking us through the development of Navigate Your Health in the youth justice context in Queensland and the early learning and outcomes we're achieving through this innovative cross-agency collaborative care partnership. So increasingly, we're seeing young people enter the youth justice system with unmet health needs and at times some significant unmet health need. And we're hearing this from our frontline staff, both in custody and in the community supervision environment. And we're also seeing this emerge in the research evidence base. For example, the studies indicating the extent of undiagnosed neurodevelopmental impairment. In youth justice in Queensland, we also run a yearly census to help us better understand the young people in our system, which is also showing us data around the extent of the complexities that the young people in our system face. And while we've always been good at connecting young people with care when they're in the custody environment, making this happen in a community environment and continuing and sustaining the efforts and gains we've made in custody once young people transition back to the community is often quite difficult. And this is for a range of reasons. And this can be because young people and families are not ready, willing or able to engage. And also because accessing the health system is really difficult. Even when people are willing to engage, the health system is difficult to access, it's difficult to navigate. And this is especially the case if you have complex health needs or you have multiple different health needs going on at a point in time, which is certainly the case for many young people who are involved in the youth justice system. So this is a quick snapshot of data from the 2020 Youth Justice Census. We don't have a lot of time, so I won't go into it, but you can see that young people in youth justice, so the census covers all young people that are supervised in youth justice on a specific day in 2020. So you can see that out of all the young people being supervised, they are experiencing significant health issues like, disability, substance use, mental health, which we know, and also other areas of their life are being impacted and presenting as complex need, including impacting by domestic family violence, having unstable accommodation or homelessness issues and challenges, or being disengaged from school or employment. So we want to improve health and wellbeing outcomes from young people because it's important. We know it's an issue. Young people and all people have right to health and to access to health care. But importantly, what we've been hearing from our staff is that when young people have significant unmet health need, it creates a challenge to effectively being able to engage them, not only in the programs and services that youth justice deliver and want to support young people with, but also in engaging them in services in the rest of the community, other health services, other community services, and re-engaging them back in school, and sometimes even in terms of effective engagement and relationships in the family and in the community. And we know that improving ability to engage in things like education, employment, and engage in programs and services that youth justice and other agencies provide is really important for improving life outcomes. And we want to improve outcomes for young people because we know improving outcomes in these key areas that are highlighted here on the screen can also contribute to supporting that young person to reduce their reoffending behaviour. So what's on the screen there are what are key predictors of reoffending that come from the evidence base, and they're the domains of the Youth Level of Service Case Management Inventory, which is a validated tool that we use to assess risk of reoffending in youth justice in Queensland. And what we want to do is increase young people's engagement in programs and services through increased health to improve their life outcomes that can also contribute to reducing reoffending outcomes. And this was recognised in the Queensland Youth Justice Strategy, which highlighted that one of the goal areas for youth justice was for children and young people within the system with trauma, mental health, disability, developmental delay, and or risk and challenging behaviours are identified early and assisted through integrated and therapeutic interventions. And this is how Navigate Your Health became established within youth justice in Queensland. So initially, Navigate Your Health was a pilot program that focused solely on child safety young people. And in 2020, under the Youth Justice Strategy and Action Plan, the pilot was expanded to test how it would work and how it could work for young people involved in youth justice. So Navigate Your Health is a partnership model, and it's a partnership between Children's Health Queensland and the Child Safety and Youth Justice Services components of the Department of Children, Youth Justice and Multicultural Affairs in Queensland. And the model is really centred around nurse navigators. And nurse navigators work to provide children and young people with improved access to healthcare, health checks, health referrals, and they coordinate healthcare for young people and families. And a number of our nurse navigator positions are identified positions. So we have a number of Aboriginal and Torres Strait Islander and Maori and Pacific Islander people appointed as nurse navigators in our program in Queensland. The nurse navigator model is focused on coordination of care, on creating partnerships within the health system, so primary and tertiary care providers to help prioritise care. It's about improving patient outcomes, developing clear healthcare goals and plans, and also facilitating system improvements, building system literacy, so better understanding across agencies about how the health system works, but also building health literacy for individuals and families. So nurse navigators are senior advanced practice registered nurses. They specialise in managing complex healthcare, and many of the ones we've appointed in Queensland also specialise in working with young people. They work across system boundaries and in close partnership with health specialists and health service stakeholders. And importantly, one of the key things they do is really negotiate for access to healthcare and make sure that the healthcare plans and healthcare delivery is timely and appropriate for that young person. So negotiating priority access is really quite difficult, and it's been amazing what we've been able to see the nurse navigators do, and their skill set in being able to plan and prioritise care is also really crucial to making it work. And I can talk a little bit more about that as we talk more about the model. So specifically, how does Navigate Your Health, what does it do and deliver? So when a young person is referred to Navigate Your Health, they are then seen by a nurse navigator who will coordinate comprehensive health assessment for young persons. So across all areas of mental health, physical health, etc. They will get the results of that comprehensive health assessment, which might be done by a GP, some by specialists. It might be coordinated through an Aboriginal medical service that they connect the young person to. They take all those results of the health assessment, they create a health management plan. They do that again in consultation with all the health providers that need to provide care to meet the young person's health needs. They do that in consultation with the family and young person, and it outlines a really clear and coordinated plan of the healthcare the young person needs to address all those health areas that they've identified as priority for them. And they, as mentioned, they've coordinated that healthcare and prioritised that healthcare for that young person. So an example might be a young person has to go to hospital to get some really significant dental work, and they have some other things going on, and they'll arrange for that person to have their dental health need and other maybe physical or some other health need all happen at that one visit to hospital, so that they're making the most of that one time that a young person's engaging in the hospital environment or at other health system. But probably most importantly, the nurse navigators spend a lot of time and effort into building young people and families' readiness to engage with healthcare and engage in the health system. They explain to young people about the program. They do detailed informed consent with young people. They talk to them about the importance of looking after their health. They do the same thing with families, making sure they feel comfortable about engaging, that they feel that they understand what's going on, that they're part of driving the decision-making and informing the decision-making. And all this effort they poured into the engagement was really built health literacy for ongoing independent health management by young people and families, and for other stakeholders that are involved with the young person and family who will take that health management plan forward and implement that with the young person. So as mentioned, Navigate Your Health is a partnership model. It's cross-government, it's multi-agency, and it requires collaboration and coordination of all partners at every point. We collaborate on referrals, we collaborate on prioritisation of the wait list, because unfortunately the demand is so high. There is a wait list in terms of the young people that need the service versus the nurse navigators that we've got. We work collaboratively around when we're working with young people who are both involved with youth justice and child safety at the same time. And this cross-agency partnership requires ongoing communication, negotiation, regular contact, and multi-level governance. And it also requires multi-level oversight, MOUs, consent forms, legal reviews through multiple areas of different businesses. And, you know, while this is, what I want to emphasize here, that achieving a sort of system level multi-agency partnership is a lot of work. It takes a lot of effort, but it can have incredible outcomes. And we've all learned a great deal about our agency, and it's really important in breaking down silos. So it's a lot of work, but it can have really, really important outcomes. And so I'd like to now shift to some of the outcomes that we're seeing from Navigate Health. Oh, thank you. So we have referred 197 young people since the beginning of January. So there's been 197 referrals. It's 183 young people. Some get re-referred. 106 have been Aboriginal and Torres Strait Islander young people, and 128 have fully completed their Navigate Your Health journey. We've seen. we've seen a range of health needs be identified. So all of those that we've identified before, but this is through the significant health assessment process. And we can see there's some really big health needs for this group of some significant health needs for this group of young people that are being addressed by the nurse navigators. And as we highlighted, what we're trying to do through Navigate Your Health is improve health so that we can improve engagement in these outcome areas for young people that we know improve their life, but can also reduce their risk of reoffending. And we've called these our medium-term outcomes. So we've set up data collection pre and post engagement in Navigate Your Health to look at how that's working for young people. And we can see here that of the 82 people that were discharged from the program, so fully completed the program, the 60 young people that fully completed the program. And meaningful engagement just means that they had a comprehensive health assessment, the health management plan was completed, and the healthcare was being delivered. We could see that for between 30% and 50% of young people, they saw improvements across all of these areas of improved health and wellbeing, so connection to primary care, level of healthcare coordination, engagement with healthcare, health literacy, and in life, key improvements in life outcome areas such as connection to community, participating in engagement in employment and family relationships. So these are the improvements that we saw post their involvement in Navigate Your Health. So these are early outcomes. We specifically looked at these outcomes for Aboriginal and Torres Strait Islander young people. We've got small numbers at this point in time. As mentioned, these are early outcomes, but we're going to continue to collect this data and build the data set to understand how it's working for young people across the state. I wanted to share a case study. I'll do that really quickly. We had a young person who was 13 years old and was an Aboriginal young person, and they came to Navigate Your Health with significant health issues, but in particular hearing issues, substance misuse, and suicidal ideation and suicide attempts. And when the nurse navigator met with the young person's mother, the mother shared with the nurse navigator that she was really struggling to care for the young person and may need to ask the young person to leave their home. And so this is a really serious situation because the young person's behaviour was impacting the younger siblings. And so the nurse navigator connected the young person with Aboriginal medical health services, connected them with mental health services, connected the mother with a family support, an Aboriginal and Torres Strait Islander family support service, also connected the mother with parenting support, and delivered the care that the young person needed. And by the end of the program, the young person had, or their involvement with Navigate Your Health, the young person had reduced their substance use, and the mother had felt supported to implement harm minimized strategies and to address the young person's substance use, and had decided that the young person was able to remain at home and felt that the younger siblings were now safe in the household. So you can see that through that provision of healthcare, that young person was at risk of entering the system or becoming homeless, and that addressing those health needs and doing that with the family was able to significantly improve those outcomes for the young person and the family. So that's our good news story from the day. We've learnt that engagement is critical, that co-locating and in-reaching is so important, that you need to do the work to motivate young people to engage meaningfully in their health and wellbeing, that having identified staff is incredibly invaluable to engaging young people who are Aboriginal and Torres Strait Islander or Maori Pacific Islander, and that it's critical that we engage parents and carers also in driving the health management plan. As mentioned, we've actually set up a research partnership to look at the benefits of improved health and how that can impact on other outcomes, including reoffending outcomes. So overall, Navigate Your Health is really promising. We can see early positive outcomes, and we're learning how to make cross-agency partnerships work, but we want to continue to assess how it works to learn more and share more about this program in the future. Thank you, everyone. I can open now to questions.
Wonderful. Thank you, Dr. Zardo. That is a very insightful presentation, and I think I couldn't agree more. We cannot underestimate the value of cross-agency collaboration. It's hard work, but the results that you've presented today really demonstrate that there is a promising outcome for young people when we all work nicely together. We really can't underestimate how hard that can be sometimes with a lot of our rules and regulations and how we can share data or even collaborate and talk about different clients. So it's just really positive to see how Queensland is really navigating through this model of care. So thank you. Look, we don't have any questions at the moment in the chat, but if anyone does have any questions for Dr. Zardo, please pop them in the chat. She will hang around and answer them in the chat. And I just want to thank you again and really appreciate your time today. Thank you so much.
Thanks very much, Sylvia, and thank you everyone for listening.
Thank you. Well, look, that brings us to our last presentation for this session. And here we're going to be talking through about photo voice, using resident voices to inform a world-first youth custodial sensory modulation framework. Here, our presenter is Luke Francis, and he is from Youth Justice in South Australia. Luke is a senior occupational therapist for Youth Justice South Australia. He also holds an honours degree in criminal justice. And Luke has worked professionally throughout Australia, Canada and New Zealand, and is part of a team who developed the multidisciplinary allied health youth justice assessment and intervention service. We warmly welcome Luke to this afternoon session. Thank you, Luke.
I'll get started and get through as quick as possible. So I speak to you today from Kasinathan Youth Justice Centre on the traditional lands of the Kaurna people, and I respect their spiritual relationship with their country. I also acknowledge the Kaurna people as the custodians of the Greater Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. So first off, a bit of a warning. The nature of photo voices means that I'm going to use some direct quotes from young people, and as most people are probably aware, their language can be pretty colourful, so consider yourselves warned. I'll go through this background pretty quickly, but I'm here today to talk about photo voice, but quickly I'll talk about where the idea of the photo voice came from. So back in 2019, the multidisciplinary team that I work in in Adelaide completed a disability screening project where we ended up completing about 250 assessments with 36 volunteer residents over a 4-week period. One of the key findings from that was that around a third of the population had significant sensory processing needs, which compares to about 4% of the overall population. Therefore, one of the key recommendations from the project was to develop a sensory modulation framework for the custodial environment. The project's being developed in partnership between Youth Justice and Dr. Ben Seller and Dr. Scott Weeks from University of SA. So occupational therapy and sensory approaches are relatively new concepts to the YJ space. So this presentation isn't really intended to go into sensory mod in a lot of detail. I'll actually talk with a colleague tomorrow in another presentation where I'll go into a bit more detail. But essentially, sensory modulation is a methodology whereby you manipulate the environment to control the amount of sensory input that an individual is receiving. So what the research will tell you about the benefits of sensory modulation is that it's proactive rather than reactive, a means of addressing behaviour, develops independent self-regulation, it supports nature, supportive nature helps foster positive relationships between staff and users, and that the approaches are considered to be a key element of best practice for the reduction of seclusion and restraint. So from our literature review and to our knowledge, this is the first time that a sensory modulation framework will be developed specific to a youth custodial facility. So in terms of where it all fits, so the photo voice is a sub-project of a larger sensory modulation framework project, and it makes up part of an environmental audit step as part of that larger project. So the framework, the environmental audit is essentially to look at determining or understanding how the environment is impacting young people in terms of behaviour and functioning. So we're using a standardised tool, the Residential Environment Impact Scale, which actually has some inherent flexibility as part of it. So this sort of standardised version of the REIS tends to use very dry, survey-based information gathering for young people. But given what we know about our population from our disability screening project, we knew that a survey just wasn't going to give us that rich information that we were after. Therefore, it was actually through a recommendation from Dr. Ben Seller from UniSA that we realised that photo voice actually fit perfectly for what we're trying to do. So what is photo voice? So basically, photo voice is a research method that uses photographs to have conversations with people about the things that are important to them. So the photo voice methodology actually is attractive to us because it gave greater control to residents. Their photos that they actually take drove the discussions, and then the process actually reduces cultural and language and disability barriers as well. We intend to publish some journal articles with more detail about the photo voice methodology. So I'm going to gloss over these pretty quickly for today, and I'll go sort of towards the take-home info instead. So the process that we actually did, basically we gave each of the young participants a camera, and we instructed, the only real instructions that we gave them was to take photos of places that make you feel good and places that make you feel bad in Kasinathan. Once they'd taken out their photos, we would catch up with them a day or two later, and we'd go through those photos to discuss what the reasons for their photos were and what they actually meant to them. So we actually had 11 participants all up. We were actually surprised by how willing and engaged the young people were with the process. Unfortunately, the timing of the project coincided with some chronic staff shortages here at Kasinathan. So we actually had more people volunteer than we could get through the project. We actually had a waiting list through the whole time, and unfortunately that meant there was a few young people that couldn't get involved that were keen to. So we didn't really necessarily, we weren't able to be really picky with who we chose, but the table at the bottom there essentially shows that if you squint and close one eye, our photo voice sample roughly equates to the overall youth justice population in SA. So given that we asked people to sort of tell us about spaces and places, one of the sort of interesting findings was that a resident's favourite or most hated place can actually be impacted by a lot of different factors beyond how does it look and how does it sort of feel. So they talked about things about who do they have to share the space with, what's in the room, how much do I like or dislike the staff or teacher that's in there, how comfortable they are with the demands that are put on them within that space, and can they find a comfortable, physical comfortable space to sit in that space. So an example is our library here at Kasinathan is one of the favourite spots because there's lots of little nooks where people can find a comfy couch and chill out. But the beauty of the photo voice process meant that while young people were happy to discuss themes of space, the actual discussions often branched into much wider conversations that gave an incredible insight into the day in the life for a lot of young people in custodial life. We've done a sort of thematic analysis of the 5 or 6 hours worth of interviews that we've done, but we don't really have time today to go into those in sort of depth individually. So the best way that I can sort of sum things up is essentially this, that day-to-day functioning for young people in our space is essentially like death by 1,000 cuts. So interestingly, at no point in those 5 or 6 hours of interviews did any young person suggest anything that could be considered as unreasonable. They inherently understood where they were and why they were here, and they understood that there were certain things that they couldn't do because of that. But the overall picture that they actually provided us gave us a really interesting view that often there's multiple factors at play on those young people at any one time. And some of those things that the young person's consciously aware of, and some of them they're more subconscious and they're not so aware of. So some of them are probably pretty obvious in terms of impacts of noise or psycho-emotional factors, relationship with staff, perceptions of whether they're being treated fairly or unfairly. But some of the other things are a little bit more sort of, I guess, harder to sort of equate. So if you consider how well we feel when we're constantly tired because a bed that we're sleeping in is uncomfortable, or we're always hungry because the portions at lunch and dinner are always too small and always unfulfilled, And then a lot of young people also talked about the environment that they're surrounded by, in terms of the visual environment, where gardens might be overgrown or paint's peeling on the walls. They can't see the reflection in the mirrors in the bedrooms because of the graffiti, and how those factors they perceive to be reinforcing the fact that nobody cares about them, and how that then impacts their sort of day-to-day functioning as well, and their day-to-day mood. So I want you to sort of visualize a young person carrying a backpack, and through the day, their experiences and interactions, the sensory input that they receive, add weight to that bag. The more factors that they get impacted by, the heavier the backpack gets, and the more difficult it becomes to carry. When the young person, what the young people shared with us showed that while they might move from one space to the next throughout the day, they often can't simply just leave the stresses behind in one room. So what impacted them in the one room is often being carried into the next room as well. So over time, those stresses accumulate in their bags and they compound, and the backpack gets heavier. And as it does, the person's window of tolerance gets smaller and smaller. And their ability to regulate the responses diminishes unless they're given a chance to unload that backpack. So eventually they might have an interaction with staff or other residents which upsets them, and staff notice that the response appears a bit out of context to the situations, but repercussions have to be handed out regardless, because to maintain centre order and also consistency among different residents. And so, which raises the question of how are we sort of responding at the moment and what it all means. So at the moment, when an incident occurs, what we normally do is we'll look at what happened in the immediate sort of proceeding before the incident occurred. And if we're doing our job, we'll keep tracing that things back a little bit further. So often we'll sort of realise that a young person might have court coming up, they're feeling a bit anxious and a bit worried. And then an intervention might be aimed at managing anxiety in the lead up to court dates. So we'd feel pretty good about ourselves. But how often do we sort of keep tracing those things back, and at what point do we stop? So which then begs the questions of how many of these factors may have caused the incident, how many factors played a role, how many opportunities were missed, and how many times that incident could have been avoided. So the framework that we're sort of now looking at from the information is essentially got two streams. We've got universal environmental adaptations and individualised approaches. Within those individualised approaches, there's essentially 3 moments in time, sort of pre-incident, where we've got proactive elimination of stresses during the sort of early periods of escalation, and then if there's an issue, then at point of de-escalation as well. And the key to all of this is individualised approaches. So it's scheduling movement breaks and those sorts of things at the same time each day isn't likely to be helpful. So photoverse has actually literally helped find a home for the sensory framework within the broader, wider continuum of the custodial world. At the beginning, I talked about a third of the population whose sensory interventions might essentially pivot on everything else. While sensory factors might be less significant for the other two-thirds of people, everyone's still carrying that backpack. It really doesn't matter if it's sensory processing related factors that's weighing them down, or trauma, disability, or communication factors. Everybody's carrying a backpack, and everybody needs an opportunity to offload that backpack. It's why multi-D allied health teams are so critical in our space, and why approaches are so much stronger when behaviour and functioning is viewed through multiple yet complementary lenses. Thank you very much. Apologies for the rush to try and squeeze that in.
Thanks so much for that, Luke. I have to say that the analogy of the young person with the backpack really resonates with me. I think it's a really simple way to articulate and translate the complexity that you're trying to describe, and that backpack getting heavier and heavier. So I think it's just a really easy way to describe the impact that this is having on young people. So thank you for sharing today. I am looking at the live chat. If there's anyone that has any questions, we welcome any questions for Luke this afternoon. I might click into the discussion forum. There's two places, the live chat and also the discussion forum. But we have a comment here from Elaine McKee, who said, great presentation, Luke. Barton Moss in the UK employ a maintenance team to ensure that the building is in awesome condition to signal to young people that they're valued.
Yep.
And lots of comfy spaces. What are your thoughts on that?
Yeah, it's definitely, the comfy spaces is definitely one thing that really came out in terms of being able to have a variety of spaces within their day-to-day world. The nature of sort of custodial units tend to be that everybody shares a lot of spaces other than the bedrooms. And unfortunately, bedrooms can be sort of viewed a little bit as a bit of a punishment, because if there's lockdowns or if there's something going on, then they spend more time in the bedrooms. And I think that, yeah, those comfy spaces outside of the bedrooms is key. And a lot of our young people talked about being able to find a comfy space, but also talked about the beauty and the power of being outdoors as well. The outdoors is one of the most important things that young people probably told us about.
Yes, certainly being outdoors and seeing the green does make an impact probably for all of us, doesn't it? So, you know, here, the way that you've been able to capture the young people's voices in the most innovative way, I mean, I personally haven't seen anything like that. And I would think that you're probably leading the way in jurisdictions around that type of capturing of information. We talk about hearing child voices, but we're really capturing those voices and listening in a really different way. So that's fantastic. Thank you. Shelley Turner also says this is great work. Probably just as impressed as I am. The OTs at Forensic Care do an amazing job using sensory modulation with patients at Thomas Embling Hospital and in prison settings. I often wonder, how could we use this to better support staff also? Any thoughts?
Yeah, so part of the sensory framework will actually be staff training and staff upskilling as well. And in that sort of pyramid model that I showed before that I had to rush through really quickly, essentially tries to show that the staff skill and the staff training underpins everything. So it really can't be undervalued of how important staff are in implementing anything. Everything rests on the shoulders of the operational staff and their skills. And I think as therapeutic staff, the more that we can help them and the more that we can support them, the better off our sort of overall responsive environment becomes. Because, as I say, they literally are the difference makers in whether something's going to work or not.
Thanks, Shelley. A really important question around workforce. So thank you so much. And look, that brings us to the end of this session. I'd like to formally thank Luke for your time and for sharing your presentation. And I hope that you all have a fantastic rest of the afternoon. Thank you so much for joining today.